Welcome to Practical Cardiology Pearls, where complex cardiology is simplified. In this video, we will talk about GLP-1 receptor agonists. The cells we see in this image are enterocytes. Scattered between the enterocytes, we can see different types of cells, such as L cells, K cells, S cells, G cells, and D cells. Because these cells are located within the intestinal epithelium and produce hormones, they are called enteroendocrine cells. For this video, the most important ones are the L cells. One of the hormones released by L cells is GLP-1. GLP-1 stands for glucagon-like peptide 1. It is called glucagon-like because its structure is similar to glucagon. GLP-1 receptors are found in several organs. Three important ones are the brain, pancreas, and stomach. So, after we eat, GLP-1 is released from L cells in the intestine. It binds to receptors in the brain and increases the feeling of fullness. In the stomach, it slows gastric emptying, so food moves more slowly into the intestine. And in the pancreas, it stimulates insulin secretion. But there is one problem. Unfortunately, natural GLP-1 does not last long. Shortly after entering the bloodstream, it is rapidly broken down and loses its effect. So, how can we make the effect of GLP-1 last longer? Later, researchers discovered a peptide called exendin-4 in the saliva of the Gila monster, a type of lizard. Exendin-4 is structurally similar to GLP-1 and produces similar effects. But there is one important difference. Unlike natural GLP-1, exendin-4 is much more resistant to breakdown, so its effects last much longer. And this discovery became an important step in the development of GLP-1 receptor agonists. Now, let's see what the 2026 American Heart Association Guideline on Cardiovascular-Kidney-Metabolic Syndrome says about GLP-1 receptor agonists. In this guideline, GLP-1 receptor agonists have Class 1 recommendations across 6 major clinical conditions: Type 2 diabetes mellitus, chronic kidney disease, obesity, atherosclerotic cardiovascular disease, heart failure with preserved ejection fraction, steatotic liver disease. So, GLP-1 receptor agonists are no longer just diabetes or weight loss drugs. They have become an important treatment across the cardiovascular, kidney, and metabolic spectrum. In patients with type 2 diabetes and a prevent risk greater than or equal to 7.5%, an SGLT2 inhibitor, or GLP-1 receptor agonist is recommended. In patients with chronic kidney disease and type 2 diabetes, if UACR remains greater than or equal to 100 mg per gram, despite ACE inhibitor/ARB and SGLT2 inhibitor therapy, a GLP-1 receptor agonist is recommended. In patients with obesity and atherosclerotic cardiovascular disease, a GLP-1 receptor agonist is recommended. In patients with type 2 diabetes and atherosclerotic cardiovascular disease, an SGLT2 inhibitor, or GLP-1 receptor agonist is recommended. In patients with obesity and symptomatic HFpEF, a GLP-1 receptor agonist is recommended. Steatotic liver disease. In patients with type 2 diabetes and steatotic liver disease or steatohepatitis with liver fibrosis, a GLP-1 receptor agonist is recommended. Thanks for watching. Let me know in the comments which cardiology topic you'd like to see next. If you enjoyed this video, please like, subscribe and share. See you in the next video.